This is Dr. Michael Trainer. I have created this video to discuss lumbar decompression surgery. In addition to the surgery, I will discuss the risks and possible complications associated with lumbar decompression surgery, as well as answer frequently asked questions by patients and also describe instructions and expectations for those who are undergoing the surgery. Lumbar decompression surgery refers to a surgery that is performed on the lower back, which is the lumbar spine. Decompression is to describe taking the pressure off the lumbar nerves. The lumbar nerves are the nerves that travel from the end of the spinal cord in the lower back, and those nerves then proceed down the legs. Patients who undergo lumbar decompression surgery are typically undergoing the surgery to treat combination of back pain and particularly leg symptoms that may include pain, numbness, tingling, or weakness. The lower extremity symptoms are due to the fact that the patient's lumbar nerves are being compressed. The compression often occurs due to arthritic changes, disc disease, and what results in what's called spinal stenosis. Stenosis refers to a narrowing of a passageway. If a patient has spinal stenosis, it means the passageways in the spine are narrowed. With lumbar decompression surgery, the stenosis is in the lumbar spine, and that is what is treated. The stenosis, again, is typically due to arthritic changes that may involve the accumulation of bone spurs, calcium deposits, also disc disease, disc herniations, arthritis in what's called the lumbar facet joints. So these changes can narrow the passageways and pinch the nerves, leading particularly to symptoms that radiate down the legs. The spinal cord is not compressed in the lumbar spine because the spinal cord ends at the first lumbar vertebrae. Typically, the decompression surgery is below the first lumbar vertebrae, and therefore the spinal cord is not itself being compressed, but rather the nerves that travel from the spinal cord and then supply the legs. With regard to a lumbar decompression surgery, it is typically performed when patients have attempted non-surgical treatments such as physical therapy or medications or activity modifications or spinal injections, and unfortunately their symptoms have not been adequately addressed with the non-surgical treatments. The lumbar decompression surgery may involve one level of the lumbar spine or multiple levels of the lumbar spine. One level of the lumbar spine, for example, would be the L4 and L5 level. Two levels would be the L3-4 and the L4-5 level. Three levels might be the L2-3, L3-4, L4-5 levels. So depending on the areas where there is narrowing or stenosis and where the nerves are being pressed or compressed, that would then predicate the levels of surgery that are being performed and the levels that are being treated. With regard to the risks of lumbar decompression surgery, the first risk we always discuss is infection. Infection can occur whenever a cut is made in the skin. To prevent infection, patients are given IV antibiotics during the surgery. The patient will often receive additional dose of IV antibiotics in the recovery room. No further antibiotics are required. Specifically, the patient does not need to be discharged on oral antibiotics. Blood loss is something that occurs during the surgery, but typically there is not significant blood loss. So it is very rare that a patient would require a blood transfusion following a lumbar decompression surgery. However, there will be some degree of blood loss, and this will always be monitored for the patients in case any need for transfusion presents. Blood clots are very rare during lumbar surgery, less than 0.5%, so blood thinners or other treatments to prevent blood clots are not necessary. The best treatment to prevent blood clots after lumbar surgery is activity, meaning walking. So we recommend patients begin light cardiovascular activity, walking, for at least 5 minutes, 4 times a day, the day following surgery. We instruct patients to walk before breakfast, before lunch, before dinner, and before bedtime, and certainly more walking, if tolerated, is appropriate. We always discuss risk to the lumbar nerves, so nerve injury, vessel injury. We do discuss spinal cord injury, although as stated, the spinal cord is higher in the spine and it is not usually at any risk. With regard to nerve or vessel injury, nerve injury can be prevented or at least monitored during the surgery with what's called spinal nerve intraoperative monitoring. Oftentimes during these surgeries, we will utilize what's called intraoperative nerve monitoring, which is a procedure that is done once the patient is asleep. Once the patient is asleep in surgery, we will have a nerve monitoring technician place needle probes from the skull to the feet and into the muscles. Those probes are attached to a device that allows for monitoring of brain, spinal cord, and nerve function to make sure that during the surgery there are no abnormalities. If there are any abnormalities, then we stop what we are doing and make sure that the situation is rectified. However, with that said, there is still always a risk of injury to nerves as we are performing surgery to take the pressure off the nerves. Another risk during lumbar decompression surgery is risk to what's called the dura. The dura is the covering of the spinal cord, the spinal nerves, and the brain. It is a thin tissue, almost like a saran wrap covering, or almost like a water balloon. And it houses the spinal cord and the spinal nerves. It also houses the cerebral spinal fluid. When the nerves are compressed, the compression also compresses the dural sac, or this tube. And in taking the pressure off the nerves, patients could sustain a tearing of the dura. If that occurs, we can see it during surgery, and we will often see a leakage of clear cerebral spinal fluid. At that point, the tear needs to be repaired, and this is done either with sutures or with glue or with a patch. If a patient sustains a dural tear, it can delay recovery because the patient usually needs to lay flat in bed for approximately 24 hours. The reason is when patients get up, they increase the pressure on the cerebral spinal fluid, which could put stress on the repair and compromise the repair. Now, dural tears are not very common, but they can certainly occur. If they do occur, the patients will certainly be notified of that following the surgery, and any precautions will be taken. If a patient has a dural tear repair that is required and the repair somehow fails, then the patients will often experience drainage of clear fluid from their incision site and also severe spinal headaches. If that occurs, then the patient might require additional surgery. Sometimes patients could have a chronic leak of fluid, which I have never seen personally, but it can happen. So this is something that we do discuss with patients so they are aware of this possible complication. Again, it's a very rare complication. Other risks are risks that the surgery will not solve the patient's neurogenic symptom problem, meaning no surgeon repairs the nerves. The surgery is designed to decompress or take the pressure off the nerves. Unfortunately, if the pressure that the nerves were under caused permanent damage, then it doesn't matter if we take the pressure off. The patient may still have nerve-related symptoms, back pain-related symptoms, leg-related symptoms that will not go away. Unfortunately, this is not something that we will know until after the surgery and after we've given the patient adequate time for recovery. When the nerves have compression, they can often take even 6 to 12 months to heal. The nerves heal by about 1 millimeter a day, which is a very small amount, and these nerves travel from the lower back all the way to the toes. So 6 months is the standard time frame to allow the nerves to heal. 90% of patients at 6 months The best that they will get is what they have at 6 months. There is about 8 to 10% of patients that might have nerve improvement that continues up to 1 year. After 1 year, most patients, whatever symptoms persist, is probably due to permanent damage. Again, we never know when there is permanent damage, but the best prognosis for patients is if they notice nerve improvements quickly after the surgery. Some patients may obtain significant improvement after the surgery, but they may never return to symptom-free back or leg symptoms. And this is something that we have to unfortunately realize, that there is a chance that the surgery will not eliminate symptoms, but hopefully the surgery will improve symptoms to a greater degree than any of the preoperative non-surgical measures we're able to provide. Unfortunately, patients may have recurrence of symptoms over time. Patients may require additional lumbar surgery following a decompression over time. Sometimes that might involve similar surgeries, or it might involve what's called instrumentation infusion surgeries. Unfortunately, 35% of patients that undergo one lumbar surgery will at some point need to consider undergoing additional lumbar surgery. Patients are typically seen 7 to 10 days prior to their surgery for a preoperative visit. They typically will view this video, which will go through the surgery and what to expect, and then any additional questions can be answered at that time. Patients will be instructed on the location and time of their surgery the day before their surgery. If a patient is having surgery on a Monday, they will be called by one of the surgery schedulers on the Friday prior to surgery. This is usually late in the day, as the surgery schedule for Monday is not finalized till late in the day on Friday. If the patient is having surgery on a weekday, Tuesday through Friday, they will be called the day before. Patients are instructed not to eat or drink anything after midnight the night before surgery, with one exception. If a patient takes a blood pressure medication normally in the morning, they are instructed to take the blood pressure medicine with a sip of water on the morning of surgery. All other medications should not be taken, and again, the patient should not have anything in their mouth to eat or drink, including gum or lozenges or certs, after midnight the night before surgery. If a patient does eat or drink after midnight, the surgery may be canceled. The patient surgery can take anywhere from 1 hour to several hours depending on the amount of decompression. If the patient is undergoing a 1-level decompression, the surgery usually takes about 1 hour. If the patient is undergoing a 2-level decompression, it might add 45 minutes to an hour to the surgery. So it might be about 2 hours, 3 levels would be 3 hours, etc. Depending on the amount of surgery that's performed, the patient may be discharged to home the same day. Otherwise, the patient may be admitted either to the surgery center overnight or to the hospital overnight. Most patients do not require more than an overnight stay, but some of that does hinge on the amount of surgery that was required and if there were any problems or complications encountered during the surgery. The discharge criteria for patients involves 3 criteria. The first criteria is that the patient's pain from surgery is well controlled with medication they can take by mouth. The patient will be issued a prescription for pain medication and a muscle relaxant at the time of their preoperative visit, and so they will have those medications at home. If the patient requires IV pain medication, they will not be discharged. The second criteria is that the patient has no complications from the anesthesia. If the patient has any issues with the anesthesia, abnormal vital signs, nausea, vomiting, then they will not be discharged until those issues are rectified. The third criteria is that the patient is mobile. The patient does not need to jog around the hospital or the surgery center, but they do need to be able to get up and out of bed. They need to be able to walk through the hallway. They need to be able to go up and down some stairs, get on and off the toilet seat, get in and out of the shower. If the patient requires a cane, a crutch, or a walker to accomplish good mobility and safe mobility, then that is fine and they can still be discharged. For driving, I tell patients that they can drive after surgery once they are not requiring narcotic pain medication and they are not requiring a walker to ambulate. And number 3, that they feel safe with driving. I typically instruct patients that if they have not driven for a week or 2 after surgery, they should go to a quiet street or a parking lot and try some driving before they get back on the road. The patient's incision will be closed with sutures. The patients are allowed to shower within 1 day after the surgery. They can remove their dressing and they can get the incision wet. Oftentimes we will place a waterproof dressing, and if the waterproof dressing is on, the patients can keep that dressing on for up to 5 to 7 days and not even change it until that time. But patients can certainly remove the dressing the day after the surgery and allow warm soapy water to run on the incision. Again, the incision will be on the back, and patients should not utilize hot tubs, swimming pools, or immerse the wound. Just warm soapy water in the shower is appropriate. Patients should pat the incision dry after the shower and apply a clean, dry dressing after the daily shower. Patients should not apply any bacitracin or ointments to the incision, just a clean, dry dressing. Some patients may experience some drainage from the wound after the surgery. A small amount of drainage is not uncommon. If patients experience significant amounts of drainage, they need to call the office. Patients are instructed not to go to the emergency room or urgent care if they have any issues. Please call the office. If it's after business hours or on the weekend, call the office and I will be paged and I will call the patient. If the patient does need to go to the urgent care or the emergency room, I will call the facility in advance and let them know that the patient is coming. But please do not go to the emergency room without calling us first. If I am not available, typically my physician assistant will notify the patient. If it's a day where we are in the office, the patient can simply come to the office if there is that type of a question. Again, this is very uncommon, but if there are any concerns, please, by all means, call us first. Some redness, some warmth, some small amounts of drainage are not uncommon, but if there is any significant amount of drainage or any concerns, severe headaches, other problems, we tell the patients, please call the office and we will get back to you quickly. In terms of post-operative visits, the patient should make a 2-week follow-up visit at their preoperative appointment. So they should schedule to be seen at about 2 weeks following their surgery. At that time, the incision will be checked, the patient will be checked, and then the patient will be scheduled to be seen at 3 weeks post-operative. At the 3-week visit, the sutures are typically removed. Patients may then be referred for outpatient physical therapy if it is required, or they may be receiving at-home therapy, which will continue. Patients will then be seen at 6 weeks. At 6 weeks, therapy may be prescribed if it is required, but if not, the patients are typically doing quite well. Some patients are doing extremely well at 6 weeks and may not require additional office visits. Other patients may be seen at 12 weeks post-op. Most patients by 12 weeks are hopefully back to improved function with decreased back and leg symptoms. But again, some patients may take a greater amount of time for full recovery. But upwards of 90+% of patients by 3 months are back doing the activities they like with typically significant improvements in symptoms. This video can be viewed on our website at AOSMLV.com. Again, AOSMLV.com, and go to the link with the medical providers, and under Dr. Michael Trainer, you can go through the videos and you look for the video that's entitled Lumbar Decompression Surgery. Thank you.